And so I'm going to start by just sharing my screen so that we could, can you all see my screen?
Yes.
Mm-hmm.
Okay. Well, good afternoon, everyone. My name is Aquarius Gilmer with the Southern AIDS Coalition. And I just want to start off by saying thank you again to Drew and the entire AIDS United team who's been doing a phenomenal job of hosting AIDSWatch for several years, but and also being very nimble and adjusting really quickly to having us have a virtual AIDSWatch so that our time is not wasted. But we've been really, really good conversations and trainings thus far today and presentations on COVID-19 and the HIV response. And so for those of you who are joining us, we also appreciate your attention during this time. We know that you could be grabbing a snack and perhaps you are grabbing lunch and some great information and some tools that you can take back with you or you could use actually in your locales where you're located. So joining me today in our presentation entitled Increasing Access to Treatment and Care in Southern Rural Communities is Carolyn McAllister, and she is the Colin W. Brown Clinical Professor Emerita of Law at Duke University. So we've been able to convince her to come out of retirement for a second for us. So we have a treat on our hands. And we have Susan Reed, who's also from Duke University. We have A. Tony Young, who's the founder of the Community Education Group in West Virginia, who will be joining us, and our dear friend Michael Murphy, who's the Executive Director of the Medical Advocacy Outreach work in Montgomery, Alabama, and throughout Alabama is also with us on this afternoon. And so I just want to give a brief overview before our presenters come in and really give us a deeper dive into what does it mean to increase access to treatment and care in the rural South. So at the Southern AIDS Coalition, our mission is to end the HIV epidemic in the South through intersectional advocacy, through capacity building assistance, leadership development, and in education, as well as research and evaluation and strategic grant making. And our vision is that one that where we envision a better South for people living with HIV, one where every person has access to high quality healthcare and essential support services free from stigma and discrimination. We also envision a South where every person understands his or her risk for HIV transmission, receives routine screening, and has access to a full range of prevention interventions and harm reduction services. And please bear with us. We are going to do a bit of reading from our slides. We understand that there are various modalities of learning, and some folks may need us to read for them because of their hearing or even vision impairment. So please bear with us as we seek to be as inclusive as possible. So how do we reach this goal? Through our SRVICES public policy priorities are the following. We seek to increase the awareness of the disproportionate impact of HIV on the South and the need for new flexible resources that can be used to mount an effective response to the epidemic. We also do this by promoting and protecting access to high quality healthcare and essential support services, which include the Ryan White program, Medicaid, Medicare, the ACA, and the private insurance partners, as well as ensuring that Southerners living with HIV and other marginalized communities are free from stigma and discrimination. And lastly, we do this through our intersectional advocacy by promoting and protecting and promoting access to a full range of prevention, interventions, and harm reduction services across the South. And at this time, I'm going to turn over the microphone to Carolyn McAllister, and she's going to describe for us what we're confronted with in the South for folks who are living outside of large rural urban areas.
Can everybody hear me? Okay. So I want to start by thanking Drew and the folks at AIDS United and the other sponsoring organizations. I can't even imagine what it took to pivot to an online venue for AIDSWatch. But I think one silver lining is that we have so many people participating who wouldn't have been able to otherwise. So that's fantastic. And really, the other thing I want to say before I start is I miss seeing you all in person, and I hope that everyone is safe and supported during these really surreal times. So what I'm going to do is try to set the stage quite briefly for the rest of the panel. I'm going to talk about, and Susan and I are going to do this together in terms of just looking at some of the data. But I'm going to talk about analyses that we did at the Southern HIV/AIDS Strategy Initiative, SASI, which has now become part of the Southern AIDS Coalition, looking at where people living with HIV in the Deep South live. And Aquarius, if I could have the next slide. Thank you. So in 2015, SASI did a study in which we looked at the percentage of people living with HIV who lived outside large metropolitan areas that were at that time being targeted by the CDC for funding. And we found that overall, 29% of people living with HIV in the Deep South live outside a large urban area. And when I talk about the Deep South in the context of these analyses, we're talking about 9 Deep South states that we have focused on, and you can see them outlined there on that map. In 5 of 9 Deep South states, more than a third of people living with HIV lived outside a large urban area. Some Deep South states bear a heavier HIV burden outside of the large cities than within them, and Alabama and Mississippi consistently fall in that category. They each had more than 60% at the time we looked at this of people living with HIV overall living outside a large urban area. So in 2018, we decided to analyze the data relating to those who live outside a large urban area. And we're defining that as the CDC does, an area with more than 500,000 population. And we decided to break it down by key populations most impacted by HIV. And we looked at 9 Deep South states, same 9, and we found that 3 of the 9 states, Florida, Tennessee, and Texas, are states that are more urbanized and therefore have consistently high proportions of people living with HIV who live in the large urban areas, consistent with what we see nationally. But the other 6 states, Alabama, Georgia, Louisiana, Mississippi, North Carolina, South Carolina, had much higher proportions of people living with HIV outside the large urban areas than we see nationally. So the breakdown differed by state, and it differed by the key population that we studied. And we did prepare individual state reports that you can still find on SASI's website. And we decided to look at these breakdowns because at the time, the CDC had continued to focus most of their direct funding to community-based organizations located in large urban areas with populations more than 500,000. So if I could have the next slide. So when we looked at the epidemic among Black African Americans living with HIV in the 6 target states, we found that overall 35% of this key population lived outside a large urban area in our 6 states that we were looking at. Next slide, Aquarius, please. And if you break it down, looking at this chart, you can see that in 5 of the 9 Deep South states we looked at, more than 1/3 of Black African American persons living with HIV lived outside a large urban area. Consistent with other breakdowns, Alabama and Mississippi stood out, with Alabama having 67% and Mississippi having 53% of Black African American persons living with HIV who lived outside a large city. Next slide. This map shows you the breakdown of combined Black and Latinx persons living with HIV. The darker the state, the higher the percentage living outside a large urban area. And again, Alabama and Mississippi had the highest non-urban percentages, but North Carolina, South Carolina, and Louisiana were also high. Next slide. And if we look at same gender loving men living with HIV, you can see from this chart that in 7 states where we had complete data, all of the states had high urban epidemics among same gender loving men. But even given this, you can see that 3 states, Louisiana, North Carolina, and South Carolina, had more than 30% of their epidemic in this key group living outside the large cities. And that is almost certainly also true for Alabama and Mississippi, but we could not get complete data for those two states on this metric. Next slide, please. Next slide. Yeah, thanks. So for women living with HIV, most states, even those with much higher urban epidemics overall, had higher percentages of women living with HIV who lived outside the large cities than was the case for other key populations. 5 of these states had more than a third of women living with HIV living outside the large urban areas. And a 6th state, Georgia, was close with 32% of women living outside the large urban area. We also, in our analysis, did look at young people aged 13 to 24 living with HIV and injecting drug users living with HIV, and all of those breakdowns are in our report. But on every metric that we studied in the 6 target states, significant percentages of people living with HIV were located outside the larger urban areas, where community organizations were receiving most of the direct CDC funding. I will say that we were pleased to see when the national plan to end the epidemic was launched, that there is a focus on some of the states with large rural epidemics. And it will, as an advocacy matter, it will be important that we monitor these funding streams to ensure that the funds actually make it to these smaller communities. There is a failure, though, in the plan to target resources to states that have large epidemics, not in the rural areas and not in the very large cities, but in smaller cities with populations between 50,000 and up to 500,000. So I'm hopeful that we will see those smaller cities included in the mix as the plan is developed and implemented. So as you can see from these slides, and I'm going to turn this over to Susan Reif next, but as you can see, especially in this time of COVID-19, we have substantial numbers of people who are living with HIV, but who are not in the very large cities. And we need to be sure that resources flow to those areas as well. I think that's going to be very important going forward, especially in this time of scarce resources, that we figure that out. So I'll turn this over to Susan for a couple of more data points. Thank you.
Can you hear me okay? Aquarius, can you hear me okay?
Yes, we can.
Okay, great. Somehow I've lost the view of my slides. So, okay, I think I see it now. So hi everyone. Virtually, I just want to echo what everyone else has said and thank AIDSWatch for this extraordinary effort to get us online. And as much as we wish we could be here in person, I'm glad to at least have this opportunity. So I'm not going to take much of your time. I just want to say I'm, for those of you who haven't met, I'm Susan Reif with the Center for Health Policy and Inequalities Research at Duke University. Our center coordinated the research aspect of the SASE Research and Advocacy Partnership. And we've been fortunate to continue to work in research in the Deep South through our partnership with the Southern AIDS Coalition and assisting with some of their evaluations of the COMPASS project. Okay, next slide, thanks. So I am gonna just talk briefly about some of the research related to HIV in the Deep South outside of the sort of large urban areas. And the first study I wanted to talk about was a collaboration that we did with SASE with the CDC, and that was to examine HIV epidemiology using the CDC data that they analyzed that wasn't publicly available. And so what we found in that study was that we found that even after controlling for factors such as race, ethnicity, age, that just living in the Deep South was a risk factor for death among individuals diagnosed with HIV. So that was obviously a concerning finding, but one finding that wasn't as highlighted at the time that this study came out was that living in a rural area or even a suburban area, so outside of a large urban area, was also a higher risk for mortality among people living with HIV. So one of the limitations about that study, unfortunately, is that it is a bit dated at this point. You can see the data was from 2010. If we were to repeat that study now, the data would probably be, current data on mortality would be about 2015 or 16. So it's not clear whether we would have the same finding, although knowing that, given the fact that we haven't really seen sort of widespread, really focused efforts to address inequities in care in rural and kind of less urban areas, it's likely that we would find the same findings, or at least something relatively similar. So we would hope to repeat that study at some point. There was a study in 2019 that showed that there was higher viral loads in rural areas compared to their urban counterparts. So I'm going to, next slide. Thank you, Aquarius. Talk a little bit about HIV-related stigma. We know that HIV-related stigma has been consistent. Well, it's one of the factors that has been implicated as contributing to the disproportionate effects of HIV in the Deep South. It has been consistently related to poor health outcomes, and research has identified that, not surprisingly, probably most of us already know, that HIV-related stigma is higher in rural areas. That was research from across the USA, including the Deep South. So we, through SASE and now through Compass, really been interested in interventions to reduce HIV-related stigma. There's not a lot in the public examine what community-based organizations were doing to address stigma. So many of you were probably asked to, those of you from CBOs were probably asked to complete a Compass-related survey about HIV-related services that did ask some about stigma. Those findings will be being released through AIDSView and Emory. But we also, at Compass and particularly at SAC, did a second, more in-depth survey looking at availability of stigma-related services provided by community organizations. And what we found, and this is preliminary research, so it's not out yet, it'll be out fairly soon, but what we found thus far is that there, again, not surprisingly, are less interventions to reduce stigma being done by CBOs that cover more rural areas, and those are interventions including like things such as group level stigma reduction interventions, individual level stigma reduction interventions, and even kind of publicity campaigns to reduce HIV-related stigma. So next slide. Okay. Okay, this is one of the times I'm really glad we're virtual and not in person, because if we were in person, no one would be able to tell what this map says. So this just came out from our map guru this weekend. I'm going to try to explain it. So of course, this is a map of the Deep South, and then you can see the areas that are just plain white are areas that we don't have data from. So some of these areas may be areas where community-based organizations are not available, and maybe rural areas, but for many there are areas that we did not receive a survey completed. But when you look at the areas which are counties in red, those are the areas that do have group level stigma reduction interventions available in their county. And so you can see those are focused more in the urban areas. But even looking at those, if you look at the red with the white dots, those are areas where the person who completed the survey said, yes, we have these interventions and it's enough for our county. But the ones that are red with the black dots are ones where there is stigma reduction interventions, but they do not feel like it's enough availability for that particular county. So you can see even urban areas do not feel like they are covered for these types of interventions. And then the areas with just the plain black dots, those are areas where there are no stigma, group level stigma interventions available, and they feel that those are needed. And those are, a lot of them are more kind of rural, less large urban areas. So that's all I have for now. I hope this can be helpful in just showing more of a need, why we need to be addressing, obviously need to be addressing HIV in the Deep South in rural areas. I'm going to turn it back to you, Aquarius.
Thanks so much, Susan. Oh, was this yours, Susan, here?
Actually, I think that's mine, but I think I already addressed it
Okay, no problem.
when I talked. So.
Oh, thank you so much, Susan. At this time, we have A. Tony Young from the Community Education Group. Tony? We're just triaging here with her. Just give us one moment.
All right, Tony, looks like we can see you. Can we hear you? You? Looks like Tony's going to try calling in. It has you as unmuted, Tony. We can't hear you.
So I'm Drew and Tony. I'm going to let you two kind of triage that.
Okay.
And then we're going to just jump to Michael and come back to Tony. How about that?
Mm-hmm.
Okay. So give me 1 second to stop the share, and then Michael Murphy will have you up, and then we'll come back with you, Tony. Okay. Just give us 1 second here. Okay. Okay. All righty, Michael Murphy. The show is all you. Wait, no. The show is all yours. Stop the share for 1 second. Sorry, y'all. sure I'm coming. All right, Michael.
All righty. So if everyone can hear me pretty good, we'll go ahead and get started. I'm going to try to go through the early part of these slides really quickly because many of you have kind of heard my program before. So Aquarius, if you'll go to our next slide. So just a quick update. We're a nonprofit. We're a 501c3 organization, and we are also a Ryan White Part C grantee, and then we do our provider for both Part B and Part D grantees in our area. And we are a Ryan White Care Act program. We are not a FQHC. So a lot of the stuff that you're going to see today is what I think people are capable, honestly, of doing at ASO levels and beyond. We can do a lot of good work. Next slide, please. So we kind of have everything in a structured zone. We've got 4 quadrants we work. Our social service programmings are really our ASO program. We are also a medical clinic. I'll point out we do PrEP and we also do NPEP, and the NPEP are for individuals who have been sexually assaulted, that we can start them on programs. We're working with domestic violence programs in our region. We're also an educational piece. We are an AIDS education training center site for the Southeast AETC. We're one of the few nonprofits actually that do this, so and are an AETC, so we're really appreciative of that. And then we're trying to meet the behavioral needs currently that we're seeing rise rapidly in our part of the state. Next slide, please. So I'm very proud to show this off. This is our dental clinic and also our in-house pharmacy. And again, as we're talking about being a Ryan White Care Act program, we've been very blessed to be able to operate and do a lot and to be able to provide our recipients and our patients with some options. So we're thankful for this. Next slide. So our service region is in a very southern part of the state of Alabama. And we are, as Carolyn and when they were mentioning, we are kind of the representation of where HIV has gone in our state. And that is, we are in an area of the state that is very much a rural and small town center. And what you see on the screen, these are the sites that we operate out of, in essence, a hub satellite project. So we have 3 hubs and 11 satellites. And the hubs are all our areas, and then the satellites are operated by our partners, and they could be at FQHCs, departments of public health, and it could be also in a collaboration we do with University of Alabama, Birmingham. And we're about to enter a couple of more programs with rural health centers, which I'm very happy about because I think that's going to open up, particularly toward the southwest portion, going more toward the Mississippi line. Next slide. So if you keep that same slide that you just saw that in mind and look at this one, this is where HIV is in essence in the state of Alabama in regard to rate. And I want to make a point of noting that those areas the darkest are the counties that have high rates. Those are heavily rural. Those are also where the larger African American and Black communities in the state of Alabama are located. And there's a precedence there that if you look at that, I can tell you without any hesitation that we have high rates of HIV, but we also have high rates of every other morbidity and comorbidity that you can think of, including diabetes, stroke, etc., primarily for a reason. And that reason is sort of based on the next 3 slides. So Aquarius, if you can go to the next slide. First and foremost, I have to just say that history impacts us on a consistent basis. So as you recall, the previous 2 slides were showing the HIV process. It shows you where we were. Well, if you look at this slide, this is indicating in 1860, where individuals who were identified as slaves were primarily located. So the larger the blue section indicates the population was higher there. This was in that period of time, the heavy plantation areas. And in essence, what you saw was today, the economic failure of that entire structure, certainly, as well as a moral failure. But the economic failure has left massive poverty rates in these regions. And if you kept looking back, this all started way back over 150 years probably ago, and now we're still seeing the legacy of that with the individuals in whom we're trying to serve. If you'll go to our next slide. It then gets exacerbated by the realities of modern era. And that is, we are in the areas, again, you can see the darker it means those are the counties that have no health providers in those particular. That doesn't mean just HIV care. That is absolutely talking about all care. And so we have counties that really have no one there to serve. And then the lighter blue meaning that they're partially covered. And so you push that with the poverty levels that were there already. You then add on this health professional shortage area. And then if you'll go to our next slide, Aquarius, the universality of the issue of limited public transportation, which has just truly been a thing that I've talked with people from all over the world, and rural communities share this on a consistent basis. And so we combined all of those, and that we were running into a significant issue. And if you look at our populations and our service delivery structure, we're serving men, women, and young people living with HIV that runs along this line. Over 70%, usually closer to 75% of the people we serve identify as Black or African American. We have about 35% right now are identified as cisgender women. We are surprisingly, in our process, the majority of the folks we serve are identifying as heterosexual. And it's kind of a mixed bag, as you all know, that how people designate is their own choice. But I do see, certainly with the high rates of infection that we see among our women, that that's probably fairly close to what we're seeing. So we have a really different demographic from a lot of places that we have to really make sure that we're serving the particular needs. Next slide, Aquarius. So in our beginnings, we are heavily rural in our focus, as you saw. So we used to go out and we would have a doctor, nurse, social workers, others riding in a van to one of our sites in the rural communities. And that has worked, but it's got a lot of economic drawbacks. And the biggest is that you have a lot of people traveling long distances, and first they're not seeing any recipient, no consumer, no patient, and that in and of itself makes it difficult. But then I'm still paying them also, which makes it tough because we are, again, are a nonprofit, and I still have to pay all of those things that any clinic would have to do. So we began to look at other options. Next slide, please. So back in before around 2010, we began to talk with some of our partner programs in the state about doing a project, and we called it Alabama eHealth. And the whole concept on it was to be able to do telemed and telehealth in a process that would benefit the recipients and the people of Alabama. Next slide. And so in the original piece, we were very fortunate to have our partners up in Huntsville with Thrive Alabama, and also Watley Health Services Incorporated, which is a 330 program in Tuscaloosa. And we were able to offer at least a telemedicine networking process to 50 of the 67 counties. And each of us used it at different levels and what we need. But when we talk about what telemed is, what we're really discussing is that you got a provider on one side at a permanent clinic, and then on the other, you have patients in rural and distance locations. So with that, you're trying to link the service directly to the recipient and hopefully be able to provide great care. Next slide. So I'll caution everybody to say we are different than an ECHO model. And the ECHO model is oftentimes thought of when they think of telemed, but with ECHO, you're talking about a medical provider talking with a medical provider. As you saw earlier, our system, we don't have many cases, doctors or NPs or PAs out in those rural areas. So what we have to do is to come up with something different. And so how we use it is a video chat concept between a doctor or a nurse practitioner and the recipient, the patient. We do high definition cameras. We do about a 1080 pixel capability. So the clarity is actually quite good. We use Bluetooth peripheral equipment that I'll discuss in a second. And then people often ask, well, how secure is it? And reality is we are absolutely HIPAA compliant, but we do a 256-bit encryption that our IT folks say matches the level of encryption that's used currently by the Department of Defense of the United States. Next slide, please. So with our peripherals, we oftentimes roll out a cart that we can use at the sites, so it doesn't get in the way when they need to move it out of the way. In our hub sites, we have larger screens and others to be able to kind of benefit easier. It makes it much easier to go in, and the screen capability is great. But even with these carts with the camera on top, they work very well. That Bluetooth stethoscope you see in the center is an actual process that we can use to be able to mate a stethoscope that our medical provider would have with our nurse, and the nurse is with our recipient, with our patient under our current model, and they're mated, so they're hearing everything going on between them. So the doctor and nurse practitioner is hearing exactly what's going on with that heart. They can amplify it as they need. It's captured in the electronic medical record system. And then we also have on extreme, we have the dermoscope otoscopes that can be used to look in the ear, nose, and throat. Again, everything can be captured, can be put into the electronic health record immediately. Next slide. So when people say, well, what can you offer? Well, we're doing medical care, and that's the initial visit. It's done in person. We're doing individual psychotherapy and addictions counseling using it, and that's really ramped up, and I'll talk in a second at how that is. We do pharmacological management. Our providers are able to meet with our patients at any of our sites, and we're expanding that out to hopefully do more in-home of that management too with our pharmacists. We can do social work and are doing social work services through our telehealth system, and then also nutritional services. We have a dietitian on staff. And then obviously we can do follow-up inpatient telehealth because we have a bridge system with our program that we can actually link into other people's systems if they need us and can do any consultation. And that we've been called on to do a little more frequently in recent weeks. But the options are there are many. And so I'm really happy to be able to say that we're expanding that, especially in the current environment. Next slide. So just give you just a quick note for all the bean counter people and an admin who want to know, does it really help? But even all those of us who are also concerned about our patients and recipients and how they're dealing with it, we currently are, as of May 31st, 2019, when I did a stop on our data just to see, we're calculating about a 5-year period of time. We had served about 912 patients. We currently are serving almost 2,050 men, women, and young people living with HIV in our structure. But over that time, we've served 912 folks through our telemed. Over 90% of our folks had said they were extremely satisfied with the care received, and the next highest was satisfied. We had no one indicate being dissatisfied with it. Two things to note, particularly at that point. We had 93% virologic suppression rate for HIV in those patients that were living with HIV and receiving care through the telehealth. And that was very helpful for us. And then we have 89% retention and care rate of our telehealth patients. And that's actually, both of those are higher than our in-person visits. So I think there's a lot of options there that we can use. Next slide. And this again for money part. For our people that we're serving, we calculated we saved over 662,000 miles of driving for them over that period to get them to their closer spot rather than them having to drive to a hub. We had over, and from our standpoint, $361,000 in savings on driving expenses. Again, for a nonprofit, that's a massive benefit for a 5-year period. And then I always want to point out, we saved driving time, over 11,000 hours of driving time. And that obviously was real helpful for us because that allowed us to see more people, because rather than being caught in a van or a car, they're able to serve through that. Now, last note on these is just to say a few things. Our recipients still can choose to see individuals in person. We still go to those sites, so no one has to take the telemed process. We are also looking at an issue right now since we've had the COVID-19 coming into us. We are really pushing heavily on trying to expand to doing in-home. So let me talk just practical aspects. So often we were stymied by third payer limits and or medical associations saying, oh no, we don't want you doing that by telehealth into the home. Well, with COVID-19, HHS has released a lot and really overcome a lot of issues that even if it's for a short period of time, we're thinking this could be a game changer for every one of us in our field of serving individuals living with HIV, that we can do more in-home processing. We've just got to think it through better, and we've got to process it. How can we be HIPAA compliant and protect information, but also provide them with options that they could use at home? And so it's been a struggle for us. We've had to link into some pieces in our system that would allow us to do more, like our doctors at the house, our behavioral therapists working from the house, or social workers, but we've been able to establish some links that I can share with you all more formally later, that we can do some pieces in there that we can maybe help others to learn how to do. And then I think the one piece that I tell everybody who is serving individuals with HIV and with rural HIV is that we've got to overcome a cultural divide there. Many times people discuss the idea, well, we have to, we got to refer back to people who remember the Tuskegee studies and others, but I'm telling you, it's deeper than that. When you talk about rural people, there is a natural aversion among rural people to really get medical care. They tend to go during crisis care and not preventative. So I just say that to you all as we look at these suburban areas, and I had a chance to listen to people that are serving more in the suburbs and beyond that used to serve in urban, and now people are having to move further out because property and housing in the big cities is too expensive. Well, they're getting out there and they realize there are not as many services. And that's what we've been saying to everybody for a long time. So now's the time for all of us to work together, both urban, suburban, and rural focus, to say, how can we make sure everybody gets these kind of services? And I do think telehealth and telemed can help. It is not going to be the complete answer. We still need people who are compassionate and mission driven. But I appreciate the opportunity. And Aquarius, I'll pull it back over to you, my friend.
Michael, wow. That was a really, really amazing presentation. And thank you. So I'm going to reserve my questions until the end, but I'm going to just for a second switch us back over to Tony so that she can give hers, and then we can go into a deeper dive here. So just 1 second.
Should I start talking to make sure you can hear?
Sure,
Okay,
go ahead. Yeah,
great.
We can hear you well too.
First of all, thank you everybody for my challenges with the internet at the beginning. That's like one of the big issues in rural communities is the internet service. And so what was happening was I had to go through my house and literally shut off every other thing that was on my internet, which doesn't normally happen, but happened today. And so today I'm just going to talk a bit about the HIV crisis in West Virginia. And next slide, I actually believe that it is in fact a crisis. I think Michael kind of hit on the institutional, I think both racism and culture that happens in rural communities. But one of the big challenges for West Virginia, which most people don't think about, is that West Virginia has a history of poor health conditions. And as you can see by this slide, we have the highest drug overdose rate death, the highest related hepatitis C, hepatitis B, and we think also Hep A. So it's been a syndemic that has been ongoing. When you think about it in the historical context, West Virginia also has highest rates of those who have not completed high school. And the challenge here, and I hate slides, so I'll talk around the slide a bit. But the challenge in West Virginia, and often people ask me, how is a Black lesbian functioning in West Virginia? I would dare to say that people of the South and people of West Virginia are some of the greatest people that I've ever met in my life, and would frankly give you the shirt off of their back or give you the last food in their cabinet. At the same time, they're very clear about help from outsiders, relationships with outsiders. And me, as born and raised in DC and now living in West Virginia and working in West Virginia, it's been about relationships and building those relationships with individuals. They may still have their issues around race, class, and sexual orientation, but once they know that you're here to help and willing to help and are a part of the community, it's a different perspective. Next slide. Pete, next slide. Oh, thanks. So one of the things that we did for CEG is that we did a project called the Equitable Access Project. And with that, what we wanted to do is really look at 14 jurisdictions in the South. And so we brought together a group of organizations to meet in Atlanta, Georgia, to talk about HIV, Hep C, PrEP, and particularly around PrEP access in the rural South. And so we met over the course of 2 days. Next slide. And over the course of 2 days, one of the things that we decided to do was that we were going to do a survey. So we did that survey during the U.S. Conference on AIDS, the 2018 Harm Reduction Conference, and then we asked a few organizations, including SAC, BAI, and others, to send it out. We, at the conferences, gave a $15 gift card for completion, and for those who completed online, they got a $15 gift card sent to them online. Next slide. As a result of the survey, we were able to get 511 respondents. And what they did is that they set a course of what were the priorities for treatment access, PrEP access, and some other areas. One of the things that, as I was saying earlier, that has happened in West Virginia, and that's, we pulled out a lot of the West Virginia specific stuff, is that West Virginia, as I said earlier, leads the nation in overdose deaths. For those of you on the call who may or may not know this, is what this has led to is an HIV outbreak in West Virginia. Next slide, please. Right? So those overdose deaths, as you can see in the highlighted red areas, and I want to get a maps person as the first presenter had, so I can get a new map done. But what we look at when we look at the overdose deaths, those are also overlying where the new HIV cases have been popping up. Next slide. What happened is also is that in 2016, CDC did a report of the 220 most vulnerable counties in the United States, looking at Hep C and looking at Hep C, HIV vulnerability. What was the likelihood of an outbreak? Of the 220 counties on that CDC list, 28 of those were from West Virginia. It should be noted that West Virginia only has 55 counties. So as you can see, the state as a whole has a vulnerability for HIV that is untold, and I think in many instances unmatched by a lot of other states. The next slide. The next thing that you'll see in this 220 county map is if I had the capacity to lay over the ending the epidemic map, the challenge here for us is that West Virginia was not included in the first round of the ending the epidemic plan, in part because of a data lag, although we, like I said earlier, had more than 80 HIV cases in 2 of our counties, maybe 3. And some of the thought is that those individuals came from neighboring jurisdictions. So if you look at this pink area, and I'm going to put my reading glasses on, if you look at this pink area where West Virginia is, and it's buttressing up against Ohio, Indiana, Kentucky. And so there's a lot of traffic, particularly traffic to purchase drugs, use drugs, but also to access services. So those borders are very, very porous. Next slide, please. So again, this is what the map of the 220 counties look like again. And so I think that you can move to the next slide, please. All right. So that is our HIV outbreak cluster, right? And what we look at is, again, those vulnerable counties. And when we see that, this is, again, based on the Centers for Disease Control 220 county vulnerable study. But those same spots, right, if we look at the southern part of the state, the eastern panhandle where I live, and up in Wheeling, there's still a need for HIV services. Next slide. Right? So our advocacy priorities that came out of our survey were to empower communities and individuals to reduce stigma around HIV, Hep C, syringe access, and reproductive health. And I'm going to focus on that, next slide, a bit. Right? So again, if we look at the Ending the Epidemic plan, you'll see that those are the jurisdictions, but West Virginia was left out of all of those counties. So one of the things that Community Education Group is doing is we have been a recent recipient of a grant through Gilead Sciences for 2 years, where we're going to develop a statewide coalition of existing providers. Those providers may be HIV providers, Hep C providers, reproductive health providers, to bring them together to come up with a plan, to work also with the state health department to prepare for phase 2 of the Ending the Epidemic cycle. That's one of the things that we feel is of critical importance in West Virginia, is preparation for phase 2, but also including both non-traditional providers as well as other providers who may not have historically done HIV work. So we're working with the state health department to actually conduct a series of statewide trainings and events to increase the number of people who are actually screened for Hep C, because there's not technically a statewide testing initiative. Next slide. And that's it. That's all I got.
Thank you so much, Tony, Michael, Susan, and Carolyn. At this time, I'm going to open it up for question and answer. And so, Drew, I'll turn it over to you to lead us through this section of our time together.
Absolutely. Thanks, everyone, for contributing this really, really rich discussion. Anyone in the chat room has any comments they'd like to ask? We have both the chat on the side, but also a Q&A button at the bottom of your screen underneath the video images of the presenters. So if you have any questions, I'll give you a couple minutes to write those down now. Okay, it looks like we have a question from Michael Luciano. Will we be able to get the slides sets presented here?
Sure, we can definitely make sure you guys have access to that. That's without a question or problem. So Drew has them, so we'll make sure that they are available. Just as a way to kind of kick off the questions, I mean, all of the presentations were really, really rich. I mean, from Carolyn laying out the HIV outside of rural areas, I'm really struck by the rural, the smaller cities and locales, Carolyn. And so if you would, could you describe for us like the challenges that exist within those smaller cities? And I know you mentioned population size as being one of the indicators that maybe CDC didn't use to think about those smaller cities, but what do smaller cities have to lose by not being included in the EHE and also other sort of funding mechanisms?
So can you hear me? So when we did our analysis, we looked at where the epidemic was outside of the cities that were greater than 500,000 population. So that included not just the rural areas, which is defined as less than 50,000 people, but also those small cities. So the analysis I presented included those small cities. And coming from North Carolina, our epidemic is really dispersed among many smaller cities like Durham, Greensboro, Winston-Salem. For those of you, there are many North Carolinians, I think, attending AIDSWatch will recognize those cities. But those cities have traditionally not been targeted for funding from the CDC for community-based organizations. And in fact, North Carolina was not included as one of the 7 states that had large rural epidemics, because our epidemic is more in the small cities. And I haven't studied outside the deep South, but I would imagine that that's true not just in North Carolina. So those smaller cities have the same, not exactly the same challenges as the rural areas, but the transportation systems are usually quite poor. The health systems may not be quite as robust as in the larger cities, and the resources just don't come their way. So that's really why I said we have to keep an eye on those smaller locations and cities.
Thank you for that, Carolyn. I see there's one question as well in the question and answer box that says, Michael, what are your best practices for encouraging folks who live in rural areas to trust the efficacy and trust the privacy of telemedicine?
So I think one of the biggest pieces for us was to get as many local folks as possible. One thing that happens is country folks love to know somebody, and they know they can link you to somebody in their network. And so if we start that off, that's first. But I think also listening to them if they express concerns, especially if we're talking about the use of telemedicine. We always tell them they do not have to use it. We'll still be coming out there. But once they get to using it, it's fascinating at how well they use it. And then they really want to participate. Because I think in some cases, the technology makes them feel more comfortable, almost like they're getting this high-tech skill. I mean, we're still doing the same medical care, but they have that. They also, if they miss an appointment, they know they don't have to wait a month before the next group comes back through. Our nurses can go out and meet them at the satellite whenever that they need to. And if we ever get to the point where we can do it in-home care to that point, if medical associations allow it, I think that's going to be a game changer, because then we could have a nurse come visit them and we can link in with their doctor from there using the peripherals. That capacity's there. We can do it now. And one thing, Aquarius, Tony had asked, and by the way, Tony did a great presentation. Tony asked, did we do TA? We do have an internal telehealth resource center. And so if anybody just needs to kind of vet it out to see if telemed would be something that their nonprofit or their program could use, we'll be glad to talk them through it. And it wouldn't cost them a penny. We just do that because we learned a lot of things that we did wrong. We don't want anybody else to go through that. So we're making sure we're going to share our knowledge with our brothers and sisters out there. And then from there, we can help them to guide them if there's a cost prospect on what they might be able to afford to do.
Oh, that's wonderful, Michael. Thank you for availing yourself to be a resource to folks who are interested in providing telemedicine. There's a follow-up question to that. Terrell wants to know, does access to technology and internet in particular play a role? So his question is, should we as advocates be also advocating for the internet as a basic utility to increase the access of folks being plugged in and connected? I think, Susan, I'm looking at you in terms of also like the isolation work among Black women living in rural areas. And should the internet also be a part of our advocacy ask of our legislators?
I will go ahead and start it, and I'm almost betting Susan's going to say the same thing. Yes, yes, and yes. Thank you, Terrell Parker, particularly for bringing that up. We've been pushing that heavily with our governor in Alabama, but I think there's an interesting thing going on across the aisles. I see Republicans and Democrats sort of embracing telemed and embracing broadband expansion. And the reason is because for all of us who are helping, we know it can offer options out in these rural communities, because there are some communities, and I think Tony, great example she was showing earlier was, there sometimes are limits, and telemed takes up a lot of energy. Now there are platforms that are coming out that we're starting to use that will help. that'll be a big benefit that require less. But when we start using the Bluetooth stethoscopes and others, it does require more. But we've got options there. No one's going to have to be limited. But I think, yes, we've got to do that. Business Republicans tend to be interested in it because of the expansion of business into their districts. So I think it's a win-win all the way around. And so if we can push that with all of our congressional and our state legislators especially, then I think it could really benefit the people that we're serving.
Well, that's wonderful. Susan, we have a question for you surrounding, so Donna wants to know, I think Donna out of Florida wants to know, is there a plan to study the increased mortality risk data that you presented from 2010? And you mentioned that it may look similar to the data you already have, but any current data that might be interesting to intersect with the EHE 2.0?
Interesting question. Yeah, I think that we would like to go ahead and study, go ahead and repeat a similar type of analysis and see if we find what we would expect to find, which was a similar outcomes. It'll be a while before we could look at any of the effects of the ending the epidemic on mortality, just because of the lag in when that data is, it can be available, but it takes a while for it to catch up. Like what you might look at that would be in the 2018 data right now is probably not very accurate, as Carolyn and I learned along the way. It takes a couple years for it to catch up. They're still adding and changing data along the way. I think that will be something really important to see if the ending the epidemic efforts that are concentrated in those kind of higher risk states like South Carolina, I think Mississippi, Louisiana, all the states that have the kind of rural concern, if some of the efforts end up having a kind of effect that we'd like to see in mortality and diagnosis rates in rural areas. So it will be an effort that we will continue to try to get funding for. And we were happy to see that they included those rural areas. Carolyn and I were particularly happy to see that that was included, as well as the urban areas, in kind of a recognition of a lot of the work I think that Carolyn had done to show that that was a concern. And in terms of the telehealth, I think time is ripe right now with what's going on with COVID to really strike and ask for that, because there's going to be more networks set up for that. Trying to keep people out of offices, all this virtual, everything's loosening up in terms of what can be paid for by, Medicaid, Medicare, schools, trying to have more availability of tele resources. So for us in HIV, I think this will be a time to really go for that, as Michael.
Thank you so much, Susan. We are actually at time, and we need to get the next group into this meeting for the 2:45 slot. But Aquarius, I'll let you finish up and sort of give a closing remark.
I just want to say thank you, Drew, again. Thank you, Age United. Thank you to all of our panelists. Carolyn, Susan, Michael, and Tony were great. I was just really enamored with the presentations and have a lot of questions I'll be following up with you guys on. If you need our contact information, we definitely have it in the PowerPoint. And we'll make that accessible to you all. I'm sure Age United has a mechanism by which that those of us who are in this presentation can actually get it. So we look forward to you all advocating with us continually, and also consider engaging with the Southern AIDS Coalition, as we also do a lot of work in the Southern state chambers, trying to do the same thing around increasing access to health equity for folks living in the South. So thank you again for taking the time. Thank you for joining AIDSWatch 2020, and look forward to seeing you in the very near future. Be well, everyone.
Thank you.
Thanks. Stay safe.
Bye-bye.